Hello friends, I am Dr. Bharat Modi from Wellcare Hospital, Vadodara. I have spent what I would think is almost an entire lifetime working in the area of total knee arthroplasty and arthroplasty at large, but certainly much more focused on the total knee arthroplasty. And on request of my fellows and students, I have decided to come up with a series of lectures which will take you through what I would consider as a primer and as an overview of understanding the science and art of arthroplasty. So, morning, gentlemen. So today I propose that we do a morning quick review of what is actually something that we should all be aware about. We are surgeons, so essentially our intuitive focus is only on surgery and surgical techniques and technology and these things. But we deal with bones. The entire purpose of whatever we do is to do with bones. And it's like a farmer saying that I will only think about plowing the earth or cutting the harvest and never think about the soil on which I am going to do all this activity. So that understanding about what is that soil is also a very important part of being a good farmer. Similarly, understanding what is it about bone health is also an important part of whatever we do as orthopedic surgeons. And bone health essentially, at the moment at least, for the purpose of this quick talk, is about osteoporosis. Osteoporosis has significant impact on the surgical techniques that we adopt in any field, in trauma, in arthroplasty, everywhere, because the purchase, the intraoperative fractures, the periprosthetic fractures, the screw purchase, which methodology might act better in terms of fixation of fracture. So all this is to do with bone osteoporotic status of the bone, and equally importantly actually, even here in this last statement I made is all about corrective actions after the damage has occurred. But as true physicians, which is what we are supposed to be, we should be thinking about preventing that fracture rather than corrective action after a fracture has occurred. And there have been significant challenges as far as this preventive part is concerned. Why? Because osteoporosis is a silent disease, silent condition. The society is not sensitized, the medical fraternity is also not sensitized to this creeping disease that occurs and affects all human beings. There are gender differences, racial differences, individual specific differences about the rate at which it might affect a particular human body. Okay. So there had been times when osteoporosis, whilst recognized as a pathological status of the human skeletal system, there were not too many options available. And even today, it's not a scientific data point I am giving, but as a common sense thing, 98% of patients as well as doctors will think that to combat osteoporosis, calcium and vitamin D is enough. Okay. So if you ask a patient or even try to introduce the subject of osteoporosis, into inverted commas enlightened and sensitized patient will say, oh yeah, I have been taking calcium all my life or for the last 10 years. I am already taking vitamin D. And this in itself, whilst useful, calcium and vitamin D, 110% it forms an integral part of anti-osteoporotic treatment protocol, is nowhere near as effective as it needs to be if you want to genuinely fight against osteoporosis and the implications of an osteoporotic skeletal system. So now I want to start off by asking at random, so that I also come to know how much are you focused on this. So let's start with you. what molecules or drugs are you familiar with in terms of those which can be used for fighting osteoporotic status?
So basically we have two classes of drugs. One is anti-resorptive drugs and another one is anabolic drugs. So the drugs could be a parathormone analog, that is teriparatide. Then we have denosumab. Then we have bisphosphonates like alendronate, zoledronic acid, and especially for postmenopausal osteoporosis, we can give hormone replacement therapy like tamoxifen. And apart from that, the other supplements that we normally use, such as calcium and vitamin D3 supplements. Yeah, so these are about majority of the molecules that we use in our day-to-day practice.
So bisphosphonates, alendronates. So you have, broadly speaking, you are classifying drugs into anti-resorptive and anabolic. Okay. Besides that, you have HRT, hormone replacement therapy, as one option, which perhaps these days is not as ubiquitously used as it was in the earlier days, now that there are other molecules, and hormone replacement therapy has its own issues. For example, it was basically instituted in women, postmenopausal women, and it had its own issues like triggering of cancerous structures, or maybe affecting the menstrual cycles and things like that. So, and now there are other easier molecules to use for the same purpose. So he said teriparatide and denosumab. Did you mention denosumab? Yeah. Any other molecule that you are familiar with? It's alright, because it's a very new molecule. So it's, no, it's a molecule called romosozumab. Okay. Now, romosozumab, denosumab, teriparatide and alendronates. These are the four molecules which are at the moment the most ubiquitously used molecules for anti-osteoporosis. So, what is your understanding of, okay, we can revisit this in a moment. What is your understanding of, again the last line?
We decrease the resorption of the calcium specifically from the bone into the plasma. Sir.
Okay, so yeah, that's good. Tell me, how would you, if you can comment, how would you have a case coming to your outpatient's clinic, and you can see by virtue of a mineral density report that this patient is osteoporotic. The T-score comes to 2.5 and less in terms of its indicative from the standard deviation. So let's say the T-score is 3.5. In other words, there is established osteoporotic status in a person. How would you think about initiating the treatment?
Because it is 3.5 and not very severe, but 4 and above is extremely severe. So for 3.5, I would start on the treatment with bisphosphonates. I would continue that for a year with supplementation of calcium and vitamin D. And after 6 monthly interval, I would do my routine blood test. I would continue the bisphosphonates for a year, and after a year, if it comes back to normal limit, that is 2.5 and above, then I would discontinue. I would just continue vitamin D and calcium supplements for a year.
Okay, fair enough. It's a fairly good and reasonable answer to have. May I ask you?
The algorithm that I would follow is that I would first get blood tests done to check the levels of serum calcium, vitamin D, phosphorus, and probably parathormone levels, and then decide what kind of treatment regimen I want to follow.
That's a very, very extremely important point. In fact, that is perhaps one of the most important reasons why I am calling this meeting today and deviating from the surgical lectures that we normally take to this. So that pre-treatment, alendronate is actually, and this is a fantastic area of discussions. So for example, the implications of cost will make me gravitate down towards alendronate, because it is the first generation, it is become now very affordable, and actually there are meta-analysis to show that alendronate also brings adequate improvement in the bone density over a 12-month period. There are studies, very well controlled international studies, which show that there are other molecules like teriparatide and romosozumab and denosumab which bring a bit better as compared to alendronate. But let's say if these are going to bring the more costly or costlier molecules are going to bring the bone mineral density to this level in, let's say, 12 months, and if alendronate brings it in 18 months, from an affordability point of view, I would still think that it's a logical choice to make. But we'll come to that later. Let me focus on this part. In the last fortnight, I have had the occasion to interact on this subject with other people who are much more focused on this area of work as compared to what I have been. And the reason for me to get involved was because romosozumab, which is the latest molecule to be brought into the armamentarium of anti-osteoporotic treatment, has just been launched in India. It is a recently introduced molecule in a commercial sense at the world level, but in India it has just been introduced. It is still not off patent, so you don't get generic versions of that like you get of biosimilars, they call it. Biosimilars in the form of for teriparatide and for denosumab, but here you don't get it. This is the original research molecule of Amgen, which is an American company, which also brought denosumab to the world stage. So both romosozumab and denosumab, these are monoclonal antibody based treatment methods, whereas teriparatide is a hormone analog, parathormone analog. I am not sure where biphosphonates or bisphosphonates are classified in this sense, but romosozumab, and I guess it was during this when I was sitting, why all of these are zumabs, numabs. So AB, I think MAB stands for monoclonal antibodies. That's why romosozumab, denosumab, everywhere it's mab at the end, monoclonal antibodies.
Monoclonal antibodies are named according to their source of origin. If they are derived from human sources or bovine sources, according to that, their nomenclature is done.
So the nomenclature has been derived accordingly. Yeah. So, but a very interesting point. Thanks. So monoclonal antibodies is a new class of drugs which are overtaking other classes of drugs in all different fields, especially in cancer and oncology, where they are targeted therapy against cancer cells, etc. But coming back to osteoporosis. So romosozumab is also a very, very strong anabolic agent. Denosumab is an anti-resorptive. However, romosozumab, now where do I come in? When did I get alarmed when I participated in these seminars over the last 2 weekends? That actually I was not even aware that we might end up once in a while having a patient go into a comatose status, having started one of these drugs. And do you know why? Huh? No, not anaphylaxis.
Because the antibodies against
Speak up.
immune, because of an immune reaction that happens.
No.
Hypocalcemia.
Yes. What happens is the denosumab, as you very rightly said, its very mode of action is that it reduces the osteoclastic activity and therefore it reduces the incoming flow of calcium into the bloodstream. So hypocalcemia can lead to sudden convulsions or loss of consciousness and comatose, and the incoming receiving physician will not even know, because this will be sudden, there will be no other background, all investigations will come normal in terms of MRI scans and everything else. So I think we have to change our protocol, and with teriparatide we have to first do a parathormone assay before we start teriparatide. So the point I want to bring in first and foremost is that starting, there are 2-3 things which I realize we need to understand. 1 or 2 are easy to implement, and the remaining one is perhaps going to be difficult from the patient's compliance point of view, and I will come to this. Whether we initiate with, and we will come to this topic about what might be the ideal way. Should we start with alendronate, or should we use denosumab, or should we use teriparatide or romosozumab or something, presuming that cost is not a part of this discussion, although that is a relevant point, so you cannot ignore that. So first and foremost, make it a point, and I want this for all our outpatient team members also to know, that before we start we need to have at least calcium estimation, maybe vitamin D, because no matter what you give, if you are vitamin D deficient, but in general we just start vitamin D, so that's a different point altogether. So calcium estimations, parathormone estimation, especially if you are going to start teriparatide, because high levels of parathormone have their own problems. They can cause Brown's tumor and so many different things. So these 2 investigations have to be done. The next thing that we need to know is that the patients have to be, you have to try your best to motivate the patient that please continue this till the end of the treatment protocol that is recommended, which means for romosozumab it is 12 months, but it is a costly treatment, 25,000 rupees per injection once in a month, that's 3 lakhs rupees in a year. For denosumab, one injection, you go for the branded thing, it can be somewhere in the even if you go for the original research molecule, Prolia, at one point it was 75,000, now I think they have reduced the price to around 25,000 or something, but that's one every, okay, so where were we? So so let me now impart to you, number 1, let's start with, in the next few lines I will now try to synopsize whatever I know about these things, which is very at the moment very limited, but it is relevant in terms of pragmatic and practical steps that one has to take. So any patient who demonstrates a T-score of anywhere 3.5 or further down should be considered as a osteoporotic person who needs active treatment. The definition of active treatment requiring would also include any patient who presents to you with what are known as fragility fractures. What are fragility fractures? Fractures which have been precipitated by a relatively very minor fall, the typical cholesis that we see in the super geriatrics, or even in not necessarily geriatric patients, someone young but who has developed osteoporosis due to things such as rheumatoid arthritis or any long-term steroid or chronic kidney disease, or so there are many conditions which can lead to severe osteoporosis at an earlier age. So any patient with one fragility fracture, because the moment you have one fragility fracture, the chances of they developing another one gets doubled, another one over the next few years. There's some criteria, I'm not too sure whether it's over the next 2 years or 5 years or something, but then one fragility fracture is a predictor of twice the further chances of developing one more fragility, and so on and so forth. So having decided that this is a case which requires active treatment, now your brain should focus on what is the treatment that I will offer. Calcium, vitamin D is a routine sort of a thing, but amongst these four molecules, alendronate, teriparatide, denosumab and romosozumab, which one would you choose? Alendronate is a good molecule. There are these newer molecules which are, perhaps there are studies to suggest that they are more powerful in their ability to deliver results. So you could consider this, but in absence of affordability, alendronate is still a good substitute rather than not having any treatment instituted. There are certain nuances to the quality of recovery. For example, alendronate is believed to create hard but brittle bones. This is going down into the depths of at the molecular level, which at the present time I am neither competent nor is that the aim of this particular morning session. So alendronate is a good molecule to have in absence of affordability, for the other higher cost molecules. Now once you come to these other three molecules, teriparatide, denosumab and romosozumab, even before you start thinking about which one to choose, get a serum calcium done, because these molecules can precipitate either hypocalcemia or hypercalcemia, and both of them are capable of creating havoc with the patient's normality. Okay, and parathormone, because if you are going to think about using teriparatide, then you need to know whether if the patient for some reason already has a high parathormone status, then it might not be wise to start teriparatide and use something else. The group of patients called the chronic kidney disease patients, they are a special group. We will talk about, or we will just refer to that later. Once you do your calcium and you find that they are within normal limits, then at least as far as the calcium is concerned, it is recommended that if you start a patient on denosumab, do one more calcium estimation at 1 month period. You give a injection of denosumab, and then 1 month down the line you do one more, because those who are going to end up, denosumab, by the way, as we referred earlier, is an anti-resorptive, so it diminishes or brings down the osteoclastic activity, which in turn reduces the calcium flow into the bloodstream, and therefore if there is going to be hypocalcemia or fall in the calcium levels, serum calcium levels, it is likely to happen in the first 1 month. If you have missed out on that, and if then your patients, they will not even come to you, because when they go into a comatose state, it's not going to be an orthopedic problem perceived as an orthopedic problem. Okay. Similarly, parathormone, if it is high, do not use teriparatide, think about something else. Denosumab is a treatment which is recommended to be used for 2 years, no more. Each of these treatments have got a plateau effect. In the best case scenario, the increase in the bone density ranges depending upon which agent you use for how long. The improvement can range from 10% to about 17 to 18%. It's not as if the bone strength becomes double what it was. And each of these therapies have a plateau effect. So you will find, so for example, in denosumab, 2 years is the max. That means roughly about 3 doses. If you take it at 9 months, it can be from 6 to 9 months. But let's say from an affordability standpoint, so 9 months, 3 doses will more or less cover that 2-year period. Romosozumab at the moment is recommended for 12 months, and teriparatide is again 18 months to 24 months. So denosumab and teriparatide both are for 2 years, romosozumab is for 1 year. There are now protocols being offered wherein you start with an anabolic and then dovetail it with a anti-resorptive. So let's say 1 year of romosozumab followed by 2 years of denosumab. You start with anabolic, and the way the so-called experts explain this is, what does an anti-resorptive do? What it does is, it prevents the eating away of the bone that is there. But if the initial bone that is present itself is low volume, then it's not as useful. आपके पास है ही 2 पैसे बैंक अकाउंट में, तो उसमें से चोरी किया तो क्या गंवाया आपने, कुछ था ही नहीं. पहले बैंक अकाउंट में भर दो आप 2 पैसे के बदले 100 पैसे भर दो, फिर आप कोई चोर को रोको, तो कुछ अच्छा काम किया आपने. तो द पॉइंट इज, with an anabolic, you first raise the volume of bone in the body, in the skeletal system, and then dovetail it to the anti-resorptive. And the anabolic agents, pure anabolic agent is teriparatide. Pure anti-resorptive is denosumab. But romosozumab has got a dual action. So I'll explain how it happens. Yes, you are right. But the dual action being, initially it is an anabolic for the first 4 months, 8 months or something like that, 6 months, and then it becomes anti-resorptive in its impact. So it is a dual, so that is why on a purist basis there is a discussion during these meetings. No, it is not to be classified here or not to be classified there. But that's more to do with semantics, you know. So how does romosozumab work? It works by blocking an agent called sclerosing. Sclerosing is an agent which, if blocked through various pathways, and these are too complicated molecular pathways, Rankel, stream and blah blah, all that. At our surgeon level, if we remember that romosozumab works by acting against sclerosing. Sclerosing is a product in the body which suppresses osteoblastic activity. So if you suppress sclerosing, automatically osteoblastic activity gets a boost. If you remember this much, that's a good enough thing. You know, there are, it seems, conditions such as sclerostosis, which is actually a clinical condition where the sclerosing production is so high or something like that, that it has an impact on bone health. For the purpose of a practical takeaway, take-home message, romosozumab 12 months, denosumab 2 years, teriparatide 18 months to, let's say, 2 years. Each one to be preceded by serum calcium, vitamin D, and in case of teriparatide, serum parathormone. In chronic kidney disease, they were mentioning things like stage 4 and 5. Now I am not even familiar with what this classification of various stages of CKD is, but initially it was considered that some of these agents cannot be used. Now there are criteria wherein if the eGFR is around 70-80, then it be better than that, then you can use. If it is worse than that, you cannot use. My point is that if you encounter in your practice a chronic kidney disease case, maybe in the early part of your prescription you refer back to a textbook and just quickly understand how to use these agents in a chronic kidney disease case. Again, the chronic kidney disease case issue is not about direct further renal damage. It's about the kidney disease making changes in the calcium levels. So that's the real underlying thing. It's the calcium hypocalcemia and hypercalcemia issue. So in a chronic kidney disease, it's even more likely that there can be a disturbance of the calcium levels. That's why you have to be sensitized about how much to use, when to stop, how frequently to monitor calcium levels, things like that. So as part of these discussions, it was as if that a patient who comes is already aware that he is a CKD patient. But if you end up getting a patient who has not been even diagnosed as CKD, So then, yeah, I mean, if there is reason to worry about it, then you should do a primary renal function blood test. And if the creatinine levels are high, then maybe before you start or parallelly to your anti-osteoporotic regimen, you should advise that patient to go and contact a nephrologist to get a proper assessment of the chronic kidney disease. So high serum creatinine means it is the CKD is there, and to be honest, I would think that you would need to reach out to the nephrologist to take his advice. Whether it is safe to start if the patient already has a nephrologist looking after the chronic kidney disease part of his problem. If not, then send and then take a counsel. All I am trying to tell you is these are powerful molecules, they are helpful, but if they are not understood properly in terms of how they should be used, you can end up having a emergency or a crisis of in a patient, and essentially monitor the calcium levels. So we have to tell this to all our boys. Two things, the two takeaway practical after all this nichod, the two things that I am saying is, maybe the most optimal way of approaching anti-osteoporotic treatment is to start with an anabolic and then switch over to anti-resorptive. Maybe this is the right way. However, before you even choose this, check on the calcium levels, parathormone levels and vitamin D levels by blood test. Make sure that your patient has understood that you cannot give up this, or you should not give up this treatment after 3 months, and mainly the resistance is because of the cost that goes with it. Alendronate is the most cost effective, after that comes teriparatide, after that comes perhaps denosumab. I don't know, no, the total cost, maybe denosumab is cheaper in the total cost as compared to teriparatide, I think. And then the last point I would like to make here is that these are highly sensitive molecules. Unless you get a truly well produced molecule, you are just giving, and the most important, I am so glad I would have missed out on this. The other thing I realized is, these molecules are all three, teriparatide, denosumab and romosozumab, all three molecules are extremely sensitive to temperature exposures. So they are supposed to be transported and maintained in a cold chain. In other words, even in your pharmacy, if that bloody thing is sitting on your shelf for more than a month, or even within that month, if the temperatures have gone beyond 25 degrees centigrade, which easily in this present day context it would, then that molecule is probably not working. When you give it to your patient, if the patient, especially teriparatide, where the syringe is going to lie with them for the rest of the month, if that patient does not have refrigeration fridge at home, then that molecule is not actually working on it. So you have to be this is actually the most important part of the pragmatic aspect of this thing, and that is that it is highly temperature sensitive. So at least in our pharmacy, please, I mean, I'm sure they are keeping it in the fridge, but also educate the patient when you dispense it, that this will have to be kept in a refrigerator, and also if possible try to see whether the sourcing that has happened, is it done in an appropriate cold chain manner. The health of the molecule, the health of the patient, both have to be properly looked at, and the prescribing team, all the different parties of the prescribing team have to understand this fact. These are very important aspects. The temperature part, I don't think anyone realizes. There is another thing called bone markers, and they have been used in structured studies. They have been used to see the effectiveness of the drug that is being prescribed. But when I went into the details, we realized that even the bone marker collection of the blood sample, they are so heat sensitive that if you think that you prescribe a bone marker and the phlebotomist comes and collects it in this room temperature here, and then it takes half an hour, 1 hour or 3 hours before they are actually sent to the lab, and from there to a central lab. Those results are absolutely not dependable at all, and this can be so dramatic. I am not sure of the genetic part of it, but what they are called, I am not even able to recollect that particular group of cells which are present in the thyroid gland. But anyway, the marker for that is a particular type of a hormone which they secrete, and if it's very high, so there were two ways of doing this. One is to do a genetic, but 25 years back genetic mapping was not all that easy, but there was this surrogate marker of calcitonin. No, it's not calcitonin. It's not something as simple as calcitonin. It was something else. Anyway, so this particular blood marker, it's basically a hormonal entity, and if it is high, then that means you have that particular gene, and it is expressing in the form of higher secretion of that particular hormone. So when we got this news from America that my cousin has it, then what happened was we got it tested here, my father's, and if the normal limit was somewhere in the range of 300, my father's blood result came 10,000. Now that means he had it, and he was already in his late 60s or something like that, at that point in time. And the only treatment is thyroidectomy. You remove the entire thyroid gland. But the worst part was that he had it had 100% transmission. So all these science is to be understood at its true level if you want to be competent physicians. Anyway, so it was an interesting discussion on this relatively small topic from a surgeon's point of view. Keep this in mind when you move ahead. Thank you. Bye. Bye-bye.